Hi, everybody. Thanks so much for joining us. I'm Dr. Angela Rasmussen. I'm here representing Public Health and Science for the Save America movement. I am here with my wonderful co-host, epidemiologist Jessica Malaty Rivera. Today, we are going to be telling you all about this week's exciting developments in immunization. Jessica, why don't you fill everybody in on what happened basically this week?
So you've probably seen in the news that a federal judge ruled in the favor of the American Academy of Pediatrics in their lawsuit against RFK Jr., specifically with regard to the changes that were made to the Advisory Committee on Immunization Practices, otherwise known as ACIP, an independent group of advisors that helps support the CDC when they make recommendations related to vaccines and the vaccine schedule and vaccine policies. And this lawsuit was presented by AAP and a couple other public health organizations. The judge spent a very, very long time looking it over and demonstrated that he really got it. And then this week ruled in our favor, in the favor of public health, by basically saying that the appointments of all of the ACIP members are not valid, and thereby all of the decisions that have been made by these 13 ACIP members that replaced 17 actual experts are also invalidated. So we've kind of gone back in time to a pre-RFK Jr. version of the vaccine schedule, one that is based in evidence and evidence-based recommendations. And we are now on hold because what the judge ruling did is essentially put the ACIP meeting, which was scheduled to happen today and tomorrow, in indefinite hold. And so we are now in a holding pattern.
Yeah, that's right. And it's actually kind of good for us because we were planning to spend probably about 10 hours today, 10 hours tomorrow covering the full ACIP meeting. Because since Secretary Kennedy fired all 17 members in June, it was June 9th, I believe, of last year, the ACIP has progressively degraded in terms of the quality of its performance and its ability to actually carry out evidence-based policymaking in terms of immunization practices. And actually, I'm the co-editor-in-chief of the journal Vaccine, and we've now published 2 papers authored by many of the former 17 members of the ACIP who were let go that essentially uses a standardized evaluation system to show that quantitatively their performance has markedly decreased. So it's good for us in the sense that we don't have to spend 10 hours watching what is effectively a complete 3-ring circus having to do with immunization policy development that has no grounding in evidence, science, or any actual data at all. And now we're just not going to have an ACIP meeting, which is good in a sense because, well, it's very good in the sense that these 13 extremely unqualified people with really no relevant expertise who are also, in many cases, very, very zealous, very, very ardent anti-vaxxers, making recommendations that will actually strip people of being able to access these vaccines. So as you said, Jess, we are now back to a June 2025 vaccine schedule, which I have actually saved for posterity with the journal that I edit. And I can say that vaccine schedule preceded President Trump's inauguration. So we are effectively back to the vaccine schedule that was entirely evidence-based. And that's fantastic news.
Which we should also note, too, that vaccine schedule is what has been currently endorsed singularly by the American Academy of Pediatrics, who was part of this lawsuit. The American Academy of Pediatrics, for the first time in history, deviated from a previously co-sponsored vaccine schedule, and they kind of did it on their own this year. And so we're back to the pre-RFK version, but also the current version that is endorsed by the American Academy of Pediatrics. I mean, we can't overstate the fact that ACIP or ACIP is an extremely consequential group. The decisions that they make have huge implications. And we've already actually seen changes in public health since this last meeting with the ACIP. After they descheduled a number of diseases to a number of vaccines to a category called shared clinical decision making, which polling data has shown both clinicians and providers and parents don't know what that means. It's essentially treated the vaccine schedule like an a la carte menu. people can kind of choose their own adventure. And as a result, we've seen a marked decline in hepatitis B vaccines at birth, a decline in other respiratory vaccines, including flu and COVID-19, and measles is on the rise everywhere. And so this is hopefully a way to reduce the bleed, to slow the bleed, because the decisions that come out of ACIP influence the kinds of conversations that parents and providers are having in the actual clinical room. And now we can go back to a schedule that is actually based in science and based in evidence, and hopefully undo some of the harm that's been done.
Yeah. And, that is the thing that worries me, I think, the most, because there's been a lot of attention brought to the decisions that the ACIP has made since the new members were appointed in June. They got rid of multi-dose flu vaccines when they removed, essentially without evidence, the preservative thimerosal, which actually isn't even used all that much, but it does withhold these multi-dose flu vaccines that are really, really important for responding to flu outbreaks, for example, in long-term care facilities where you need to vaccinate a bunch of people all at once. Also, in other countries where there may be issues with the cold chain, where there may be issues with getting vaccines out to as many people and many children as possible, using the single-dose vaccine vials that are used here that don't require thimerosal. Thimerosal creates opportunity for that as well.
I think I read that only 4% of vaccines have thimerosal in the United States, and it's literally for those multi-dose vials, specifically for flu, specifically for congregate settings. Kids are not getting vaccines that have thimerosal in them, and they have not for decades.
No, not since, I believe, 2000. Then there was less evidence than there is now that thimerosal remains not harmful. It doesn't result in accumulating mercury, which has been the accusation. Data to that effect was presented anyways. It was actually fabricated, including a report that was made by an LLM that included hallucinated references, which were quite easy to detect because, the report was released and people fact-checked it and saw pretty clearly that the CDC's anti-vax expert, who used to be the president of Children's Health Defense, which is the anti-vax organization that Secretary Kennedy founded, presented this disinformation about thimerosal, and the ACIP removed thimerosal from the schedule. They did the same thing to the MMRV, that is the combination measles, mumps, rubella, and varicella or chickenpox vaccine. It doesn't get rid of either of those vaccines, the MMR or the varicella vaccine, but it just removes one more option to get that vaccination as a single combination shot that is given twice over the course of several years, I think.
Yeah.
And they also have reinstated the recommendation for the HBV birth dose, as well as repealed what Jessica was talking about, the shared clinical decision-making. So I want to just briefly discuss that a tiny bit more, because this is one of the things that they have used pretty effectively, and I think they're going to continue to do it because it's actually not a policy thing.
Right.
They say shared clinical decision-making, which theoretically means you go talk to your doctor and make the decision that's right for you with your doctor's advice. They are pretending that this is the same thing as informed consent, which means that no matter what, whether you talk to your doctor or not, you are getting all the information that you need in order to make this medical decision for yourself, having all the information to make it. So informed consent is required. There is no such thing as getting a vaccine without informed consent. If you do, that is illegal.
Right.
We do not force vaccines. The CDC schedule are recommendations. They are not mandates. So the discussion about how shared clinical decision-making is somehow going to improve informed consent and allow people to have more information about vaccines, have greater medical autonomy, is just a complete lie, because they actually already get the information that they need. They don't. They can certainly request it, and in fact, they should complain because they are supposed to by law. So people can get the information they need to consent to vaccination. They also can access those vaccines without having to make a doctor's appointment, without having to have health insurance to cover that doctor's appointment.
That's right.
Not having shared clinical decision-making actually means that people are more informed, they have more autonomy, more freedom, and better access to those vaccines that will really save them and their kids' lives.
Well, and it actually is even more sinister than that, because the CDC updated their website to describe what they meant by shared clinical decision making. And I want to read a sentence which actually is horrifying. ACIP makes shared clinical decision-making recommendations when individuals may benefit from vaccination, but broad vaccination of people in that group is unlikely to have population-level impacts. An absolute lie when you think about some of the vaccines in which they've put under this category, including hepatitis B. Hepatitis B is a virus that causes a chronic disease that at a population level, if is not prevented, can result in horrific outcomes for almost 90% of children or adults who are exposed as infants. There's a 90% chance that will result in a chronic infection. It can lead to cirrhosis, it can lead to liver cancer, it can lead to death. And so we've known that by intervening as early as the day the child is born, has a population level impact. And that's why we do it, because even if an individual may be hepatitis B negative, even if you think your risk of exposure might be low, the benefits to the community, to the population, far outweigh the benefits to the individual when the risk of that vaccine is so low. So this to me is just proof that they're trying to rewrite basic language when it comes to the idea of consent. They've, for the longest time, said that it has not existed and painted pictures of forced vaccination or vaccination happening almost outside of the approval of parents. Also ignoring, like you said, a very legal requirement, which is the distribution of a vaccine information statement. It's a legal document that is formed by the CDC that is required for every single dose.
The FDA.
That's the FDA that's administered. And so it's a little bit of revisionist history to kind of say, well, we haven't been doing this in the past, so we're here as heroes to save the day, and we're going to rewrite it and do it in a different way. But if you look at the fine print, what they're trying to do is make every vaccine completely optional, because they do not want to accept effectiveness data. We saw this with Casey Means. Yeah. Casey Means could not even affirm the fact that flu vaccines on the whole population level reduce hospitalizations and deaths at a population level. And so it's very scary right now, because we are actually arguing about some of the most provable endpoints.
So I'm so glad you brought that up, because I do think that there is something really, really Orwellian about the way that even words are used.
Yeah.
They are redefining what words mean effectively when they're talking about immunization and public health. And for almost everything in science and public health, we have really, really specific terminology. We're famous, in fact, for using really terrible jargon that the public finds completely inaccessible and completely impossible to understand. And sometimes, if I hear my colleagues from another field talking in their jargon, I have no idea what they're talking about either. This makes it very difficult to explain to people, what the risks and the benefits are of vaccines. And unfortunately, vaccines are really a victim of their own success, because when vaccines really essentially put a disease into submission, and with hepatitis B, the birth dose being implemented in, when was it, the early 90s?
Yep.
Has almost eliminated HBV from the U.S.
A chronic disease.
If we had continued that, we would have eliminated HBV completely from the U.S., which would be a tremendous achievement. Today I thought of actually another success story, and talking about Casey Means really made me think about this. So she said she wouldn't answer the question as to whether or not flu vaccines improve outcomes.
Yeah.
Not whether they even save lives, but do flu vaccines even work?
Right.
Well, not perfectly, and we all know that.
Yeah.
And people love to point at years when there was a historically low, effectiveness rate it was a bad match or whatever. People act like the flu vaccines don't work at all. But you know what? Something happened during the pandemic. These same flu vaccines that don't work very well, when combined with public health measures like staying home, like wearing masks, like social distancing, like testing, like reporting, like managing health data effectively, combined with vaccination, eradicated Yamagata influenza B lineage. So there used to be 2 flu B strains in the flu vaccine, Yamagata and Victoria. Yamagata has not been seen since 2020.
That's right.
And it wasn't because it just vanished, and it wasn't because of magic, or it wasn't because we just decided no more Yamagata, or we're not going to test for it anymore. We literally have not seen this virus since 2020 because guess what? It couldn't find any new hosts to infect. Every virus is an obligate parasite, and if it doesn't have a new host, it is a dead virus that is not going anywhere.
Yeah.
We eradicated influenza B virus, Yamagata lineage, without even trying with these vaccines that don't work very well and basic public health measures.
Yeah.
But the problem is, it's really hard to communicate to people that that's a success because what the hell's flu B?
Yeah.
Much less the Yamagata lineage. Who cares?
Right.
Like, nobody cares about this stuff. They just might notice that they're not getting flu this spring, which is when flu B epidemics occur.
Yeah.
So it's really, really hard to talk about the wins because the wins are actually nothing really bad's happening, but nothing really cool's going on.
Yeah.
It's not very visible. So that's kind of leads us into, I think, the next thing to talk about. Like, where do we go from here?
Yep.
Like, what does this really mean? Certainly, Kennedy can appeal it to the First Circuit Court. Eventually, it could be appealed to the Supreme Court, depending on what sort of strategy they're going to go with. It's also not clear what strategy they are going to go with at HHS because there's been quite a lot of reporting from the Wall Street Journal and the New York Times that, you know, Kennedy is sort of being reined in terms of the crazier, go wild on infectious diseases, health stuff. In time for the midterm elections. But I don't actually think he's going to go less crazy. I think he's just going to be quieter about it.
Yeah, I do think that the short leash is in effect. I also, I think the pause is both good and concerning, right? So we know that like there are a couple scenarios that could play out. They could have a knee-jerk reaction and just try to replace the 13 members that, you know, those appointments were stayed with another 13 people, perhaps a combination of older, new members. But the judge also ruled that this was in essentially a violation of the Federal Advisory Committee Act because, surprise, there are rules on how you develop a committee. They have to be credentialed. They have to be sufficient to meet the criteria of the job description. And the judge found, and he went by name of all 13 people and said, these people are not the right people for the job. And so it seems unlikely that they'll just do a swap. It seems unlikely that they will do any sort of meeting under the banner of ACIP or CDC because that was explicitly denied by the judge, though we have seen complete, defiance to previous court orders. They could potentially, try to play nice and get the old members. I don't think that's very likely. I think that was a very specific, targeted, personal attack on so many of the people that were previously on that ACIP. Those people have written, like, as you said, opinion pieces and articles for Vaccine, the journal. But what concerns me, though, it's like, but when I said it was both kind of like a relief and a concern is, this would be the time, because VRBPAC just met to discuss adopting the flu strains. This would be the time that the ACIP would be meeting to discuss the upcoming respiratory virus season.
Yeah.
Flu, RSV, and COVID-19 are seasonal viruses. They come up every respiratory virus season. And this would be the time in March and in the spring and the summer to prepare for that. And now we have everything on hold. So there's a lot of questions and uncertainty about what this means about the ability to protect ourselves in the future. What do you think about that?
I mean, I'm really concerned about this long term. Normally, the ACIP meets 3 times a year. And in the before times, I have a lot of really unhealthy hobbies. And one of them is actually cataloging and annotating all of the old ACIP meeting minutes going back to the original ACIP meetings in 1964. It was amazing, though. Like, John Enders led the measles work group. John Enders is the scientist who developed the measles vaccine, won the Nobel Prize for his achievements in vaccinology and tissue culture. And it's really wonderful to read that, but I digress. I've read a lot of ACIP meeting minutes, and so I've seen the way that the ACIP used to perform at the most recent ACIP meetings up through April of 2025 when ACIP was competent. They would cover virtually every single vaccine that is recommended at all on the schedule, and some that aren't recommended on the schedule, or some that are only recommended in very special circumstances. And I'll even give you an example. A good friend of mine went to the Caribbean on vacation and came back with what we think is dengue virus infection. Now, there is a brand new dengue vaccine, but the dengue vaccine is particularly complicated because if you do the dengue vaccine incorrectly and you've already had dengue, in some circumstances, it can actually put you at risk for more severe dengue disease. So that is a vaccine that needs to be very specifically recommended to people who might benefit from it because there are significant risks to it. Like I said, though, it's a very new vaccine. And the reason why all of these ACIP minutes are so long and tedious and boring and include so much data is that for literally every vaccine that they recommend, they continue to monitor them and look for safety signals and look for groups in which, there may be some sort of counterindication for taking that vaccine. And if they see that, what's called the safety signal, they will begin to review that. They typically would review it in great depth using a work group where they would get, patient records, things that the public doesn't actually have access to really see if whatever signal they're seeing is related to the vaccine. And then under what circumstances is it related? Do we need to de-recommend this vaccine altogether? Or will it still benefit some people, but not others? And so there are a lot of vaccines like that. There are, especially for emerging diseases that maybe might not be in the U.S., but are coming here, like dengue, which is transmitted by mosquitoes. As climate change advances the species that transmits it further northward all the time, more and more people are at risk and probably have no idea. When my friend, who is not a scientist, told me I have dengue virus and started listing off basically a textbook description of dengue symptoms, most people don't know what that is. And the only reason she did is because she told her doctor that she was in the Caribbean and there happened to be a dengue outbreak that she didn't know about.
I unfortunately know that, Hel. I got dengue fever when I was in the Caribbean years ago, and then actually started experiencing the symptoms in a country a week later that was very unfamiliar with the disease because it's such high altitude, the city that I was in. They looked at me like, we don't have what you're describing here. And it was as literal as its nickname, bone crushing disease. It really felt like my bones were being crushed. And I've followed the dengue vaccine data for a while, knowing that that's actually probably not a good thing for me because I've had dengue in the past, which again, we don't just create vaccines to just give to everybody the second they come out, right? They are very specific recommendations for very specific populations, very specific geographic locations. It's just so much more thoughtful than people are making it out to be.
Absolutely. And, I will say that I worry a lot about vaccines like dengue because, as you were saying, it's a really complicated vaccine.
Yeah.
So I've never had dengue, as far as I know. You'd have to get an antibody test before getting that vaccine. But the risk is that if you get infected with another essentially immune flavor of dengue after your first time, you can develop hemorrhagic fever, which is even worse than the bone crushing disease.
Way worse.
Described.
Do not want that.
So you don't want to give the vaccine to somebody like Jess, who's already had one serotype of dengue, because it could actually make her more prone to that outcome.
Right.
Somebody like me who's never had dengue might actually benefit from that vaccine, but only if I go to a certain place that has active dengue transmission and I'm going to be there for a certain amount of time. Because all of these things have been taken into account by the ACIP in terms of assessing quantitatively with evidence who would benefit from this vaccine and who wouldn't. And so going forward, simple things, simple routine recommendations for this year's updated flu shots, for this year's updated COVID, for RSV, for all the respiratory viruses you mentioned, for all the emerging viruses you mentioned. You're absolutely right. Even some of the best vaccines, and I've had two of them, classic vaccines, yellow fever and vaccinia, Mpox, smallpox. So I work with Mpox virus, so I've had that vaccine. I took a third generation vaccine, which has fewer side effects. It's less reactogenic. The reason we don't give everybody that vaccine, except for the people who are at risk of being exposed to Mpox, is because of the second shot. I looked like Popeye.
Yeah.
I mean, my
Gnarly.
bicep like was the size of a basketball. Yellow fever, that was the roughest vaccine I've ever taken because it's a live attenuated vaccine. It was one of the first live attenuated vaccines ever made. Provides immunity for life, but it has a lot of side effects.
Oh yeah, I've had that one too. I mean, let's think about
The only reason I got those vaccines though was because I was traveling to places, and that changes. So this is my thing. Like ACIP recommended, or actually it was NACI because I got them in Canada, but the Canadian version of ACIP recommended that I get those because I was traveling to a part of the world where I would be at risk for them. And in the case of yellow fever, I actually needed to enter the country.
Yeah.
But, you know, I got those vaccines based on an evidence-based risk assessment because I would benefit from them. But because of their side effect profile, somebody who doesn't need them and it isn't at risk of getting those viruses doesn't need to get them.
That's right.
And this is how we have actually regulated immunization over the past, over the past decades.
Right. I mean, it really does focus on individual benefit, but it also focuses on population benefit. And those two things are not mutually exclusive. And it drives me crazy when people forget the fact that there are vaccines in the standard schedule that some people are not eligible to get because they're immunocompromised, because they're of a certain age group, because they have some sort of like proclivity to an adverse event, which adverse events happen. Anybody who denies a vaccine adverse event is not being honest. We are not saying that they are risk-free interventions. There is risk. We can also say that the benefits outweigh the risk. But I also know that when my kids are getting vaccinated and there might be a kid in their class who couldn't get that vaccine, they're not just helping themselves, they're helping their friends who cannot get those vaccines. And so we're kind of like losing the plot here on the why. And I think that the next several years are going to be having to explain again why we vaccinate, the reason why certain people get vaccines, and even just thinking too about the way in which we make these processes happen. I mean, this judge who's not a scientist understood that there are protocols that need to be followed, both in creating a committee and in how we review data, which we have not seen happen in this version of ACIP. We have seen cherry picking and arguments over nonsense for the last year.
Zoom muting. I love the Zoom muting discourse. I think this is probably my biggest concern, so I was so happy to hear this news on Monday, when it came out, because yay, all the vaccines are recommended and people can easily avail themselves of them. They will be covered by insurance. They will be covered by the Vaccines for Children program. They're already covered by alternate recommendation schedules like the AAPs, as Jessica mentioned. But, this didn't start when Robert F. Kennedy Jr. became the Secretary of the Department of Health and Human Services. This started a long time before. Now, it's still Secretary Kennedy's responsibility because he was just casting a lot of doubt, spreading a lot of lies, spreading a ton of disinformation, false information to discourage you from getting vaccinated. And in some parts of the country now, we are seeing this with measles. People have been declining vaccines for long enough, for years, that now they have school-age children that are driving these explosive outbreaks because there's just simply a critical mass of kids who are susceptible to measles and who can get it. And there are enough of those around the country that we're seeing it ping pong from one to the next. And now we're seeing it ping pong into ICE detention facilities. We're seeing it ping pong into other countries. We are seeing it tearing through our schools. So this is not something that happened overnight, and it's not something, unfortunately, that this ruling is going to fix.
No.
There are also going to be a number of other administrative attacks, I suspect, including at FDA, including attacks on the vaccine injury compensation program, including taking other issues such as glyphosate, such as food, such as environmental stuff, and using it essentially as a pretext to further decrease trust in public health, science, and immunization at all of our peril.
Yeah.
Because we're going to wrap up here now, but I just kind of want to talk about very briefly about some of the things we're going to be doing in the future on this topic. On Friday, I will be hosting a live fact check of a talk. We're calling it the Freedom from Science Lecture at NIH. NIH Director Jay Bhattacharya has invited 5th Viscount Matt Ridley, the first gentleman in more than a century to drive a run on a British bank, built a naked woman's statue on his family's estate from the tailings of his open pit coal mine, is a climate change denier, and believes that the pandemic started in a lab funded by Tony Fauci. None of those things are true, except for the naked lady statue. He did make that. And he caused the bank run. In any case, he will be giving a talk at NIH, which is being advertised as a freedom in science lecture because he's such a brave contrarian coming to share his academic dissent. Too bad it's all lies. So I've got my colleague Christian Anderson, who's one of the original scientists accused of covering up Tony Fauci's role in the beginning of the pandemic. My colleague Gigi Granval, who is a biodefense expert, and of course me, who has also co-authored papers on the topic. So we'll be doing that Friday. You're going to want to come join us because it's not actually about the origins of the pandemic. It's about justifying completely scrapping, illegally impounding, and stealing the entire NIH budget. Because if research causes pandemics, boy, we don't want to do any more of that research. We'd be better off giving that money to Russell Vought and President Trump.
So given the volatility of what's happening in the legal side of this argument with the AAP versus RFK Jr. and just all of the every single day changes that we're seeing to science and public health between the NIH, between CDC, we are going to be following these things super closely so that you don't have to. And we're going to be sharing this coverage, the making sense of it all, the explanations and the debunking and the how does this apply to you lessons very regularly on both of our Substacks. You can find us at Rasmussen Retorts on Substack and Making Science Make Sense on my Substack. We will be there very often, both live and in long form content to make this all make sense to all of you.
And you can certainly always find us both at the Save America movement as well, where we are, carrying the torch for public health and science and democracy. So please join us there at our Substacks, anywhere you get your Angie and Jessica and vaccination information. And we are here. We've got you covered. Thanks so much for joining us, and we'll see you next time.
Thanks, everyone.
Take care.